Good morning, and thank you all for joining us from wherever you are. This is Ann Brazo, MPN Advocacy and Education International's founder and CEO. If you don't know me by now, I've been around for a long time, since 2004 in this space. Because of the pandemic, we have been extremely busy helping you in different ways instead of seeing you in person, which has been very difficult for all of us, I know. But the next best thing, and thank God for this technology, even though I'm terrible at it, we have been hosting online programs, webinars like this. We decided to do conversations with MPN Specialists because at most of our programs that we've hosted online and even in person, sometimes people aren't able to ask all the questions they would like to ask our specialists. And so we're doing a series of these. We've completed one. We've also completed several online programs with many of the physicians. And you're welcome to view those on our website. And those are in videos on YouTube, and they're very interesting. And especially during this pandemic, at the Women in MPN program, many of the physicians spoke about telemedicine, what you need to know as an MPN patient right now, when you should see your doctor, when you can stay at home and keep doing what you're doing. And also there were several questions that came in this morning about whether or not you should be vaccinated. And from the consensus we've gotten here from all of our experts is yes, you should, but I'll let Drs. Jamieson and Dr. Pettit speak to those questions briefly. And also Dr. Mesa is joining us. He has been delayed in San Antonio at the hospital, but he will be here at 12:30. If you can imagine what things are like in Texas and all over the country really, but particularly where he is, and he's just swamped at the moment, but he will be joining us soon. So without further ado, well, first of all, sorry, I have a little housekeeping. You have your housekeeping notes there. I can receive all of your questions. Any question you have, just jot those, send those to me directly. You can email them. I know you have your space on the right that you should be able to just jot a question down. I receive those, and then I will ask the specialists those questions. If I don't get to yours, we write them down and we get them anyway, and we will try to figure out a way to put them on our website and get answers to those questions that we've missed. I would like to thank our industry partners. These programs are never possible without their help. Insight Corporation, Geron, Bristol Myers Squibb, Sierra, Cartos, CTI Biopharma, Imago, AbbVie, Pharmacentia, Constellation, Protagonists. We thank you all very much for helping us, and Acceleron. We thank you very much. We would not be able to do this without your help. And without further ado, I would like to introduce Dr. Kristin Pettit. If you have not seen her at our previous events, Dr. Pettit is at the University of Michigan, not far from us. She has been very wonderful in helping MPN patients. And I want to hear and want her to share with you the work that they're doing in her lab and at the University of Michigan. Dr. Pettit.
Thanks so much, Ann and Kathleen and everyone else. It's good to connect with everyone virtually like this. It feels like it's been a long time, so I'm glad that people could tune in and everyone get together today. I'm here in snowy Michigan, snowy overcast Michigan. I hope most of you are somewhere sunnier and nicer than this right now. So I work here at University of Michigan with a big, diverse group of MPN researchers. Our group's working on everything from defining the genetic and biologic drivers of these diseases to identifying new targets for treatment, and then testing those treatments in both animals and in human beings. So I mainly do the last part, which is clinical trials of new treatments for patients with all different types of MPNs. I think it's been a very productive last year or two in the MPN field as far as new treatments. So it's been a really fun and exciting time to be a part of this field. And we can talk more about some of the specific drugs and trials if anyone is interested, but there's another completely different thing that we're working on here at University of Michigan too. Many of you have probably had a bone marrow biopsy, or maybe more than one, throughout the course of your disease so far. So as you all probably know, bone marrow biopsies are not the most fun things to go through, particularly for patients with MPNs, where the bone marrow tends to be pretty packed with cells and oftentimes have some of that fibrosis in there, which makes getting samples quite difficult oftentimes. Also for us, they can be difficult to interpret, as opposed to some other diseases like leukemias, where the bone marrow is more uniform throughout. I think in MPNs, it can be a bit more patchy. The fibrosis and the cellularity can be a bit more patchy throughout. So one direction that we've been going recently with the help of our radiologists is to try to develop a new MRI technique to try to look at the bone marrow as a whole, as opposed to just one 1 centimeter snippet as far as what's going on with patients with MPNs. So we're developing this new MRI technology to try to save patients' bone marrow biopsies and hopefully get a more clear idea of what's going on with an individual as a whole as time goes on with their disease, and as hopefully treatments work throughout the course of their disease. So that's just a little brief summary of the things that we're working on here.
Kristen? And Dr. Jamieson is with us. They're helping her with some technological issues, but she will be with us momentarily.
Thank you, Anne.
In the meantime, oh, there you are. Hi, but I know we're still waiting for your.
I just don't think the webcam's going to work. I hate to say it.
I'm sorry. Oh, there you are. Okay, it's a still of our lovely Dr. Jamieson, who I adore these people so much. And Dr. Jamieson, would you like to give an update of what's happening at the University of California, San Diego, at the Moores Cancer Center? I've had the great experience of being able to visit Dr. Jamieson there. And would you like to share what's happening there and any pre-ASH information you can share with the audience?
Sure, thanks, Anne. And Kristen, nice to see you by this webinar. I wish I could be seen, but anyway, yeah, so there's a lot going on in the MPN field, and I'd like to say that MPNs don't stop for COVID. So our biggest push right now is to try and get the vaccine for people. There's the Pfizer vaccine, the Moderna vaccine, as well as AstraZeneca, coming up with about 95% basic efficacy. They haven't really been tested in people with compromised immune systems, and so that's going to be the issue going forward. Certainly everyone should get their flu vaccine because we don't want the double whammy of the flu and COVID, so I think it's very important for people to get that. And the vaccine should be out by end of December for healthcare workers, so that will make people safer when they go to their clinic. We're also doing an unbridled campaign for testing everyone. So everyone who comes to my clinic gets tested before they come to the clinic to ensure that everyone knows that they're safe, because within 48 hours people have had their tests. So that we're trying to ensure safety that way. In terms of what's going on in MPNs, for diagnosis, we're really, embracing molecular technology with next generation sequencing to look for mutations. We do a panel of next generation sequencing that includes about 155 mutations, and really do that sequentially in patients to see, is their mutation burden increasing over time, and using the mutation enhanced international prognostic scoring system to help with choices in terms of what kinds of treatments people should get. There are also new single cell sequencing tests, including the Tapestry system that we're trying to employ, that looks at what's on in a single cell at the cell surface and what's on inside the cell in terms of mutations. We're starting to develop a collaboration with a company called Illumina. And with Illumina, we really want to see if we can develop tests that can be done at home for patients, and that may have an app for that, just as we have for COVID tracking. So we're working to make an app so people can track not only their DNA mutations, but RNA alterations. And I guess that's the biggest find that we've had here recently, and that is that changes in not the DNA, but the RNA and splicing and in what's called editing appear to predict progression of myeloproliferative neoplasms like myelofibrosis to acute myeloid leukemia. And the good news is we can intercede, we can prevent that using a splicing modulator or even JAK2 inhibition to prevent editing. So there are a lot of really exciting things going on. I think the most exciting thing is the field has moved ahead so quickly with new approvals, and Rebic was approved last year. We've got, as a JAK2 inhibitor, we've got a lot of clinical trials coming up that are combination strategies with a JAK2 inhibitor plus Nevidiclax, JAK2 inhibitor plus BET inhibitor. So, you know, I think Pegasus also has a place, the interferon related drug, together with a JAK2 inhibitor. So we're just seeing tremendous advances in the field that I think will halt progression, and I'm very optimistic for the coming year.
That's great news, very good news. And you mentioned RNA, Dr. Jamieson, and I believe it is, I'm trying to think here, is it Pfizer's drug or Moderna's drug that deals with the RNA?
Yes, so actually they both are RNA substrates. So everybody's having to learn about RNA. So if you think of DNA is like the architect's blueprint for your house. RNA is what the engineer decided to do to interpret that blueprint. And then protein, which is what's made from RNA, is the builder's idea of what should be used for building material. And you need all three to make a house. Unfortunately, the engineer or the RNA goes awry a little bit more quickly because of its capacity to change in response to inflammation. So the good news is if you reduce inflammation, you may be able to reduce these changes that lead to progression of these myeloproliferative neoplasms, be they essential thrombocythemia, where you make too many platelets, polycythemia vera, where you make too many red cells, or after you've scarred your bone marrow down, and that's called myelo, which means bone marrow fibrosis scarring. So I know that the group on this webinar are extremely savvy, so you know, I don't need to define all the terms necessarily, but I think it's important to say now we're really striving to reduce fibrosis, and just judging what from what Kristen said, we may be able to image it with MRI imaging, which I think is a really clever approach and something that a lot of us have access to, but you need to have a protocol for the radiologist to follow so they know to look for it. And that's certainly less invasive than doing a bone marrow biopsy. So I think that what we're moving towards in the MPN field with your leadership and in the MPN Research Advocacy Group is less invasive monitoring, be it by MRI imaging or by these molecular tests that involve a few drops of blood. And you know, we also have the capacity to compare that to saliva. So I think that one of the questions I get asked the most is, did I inherit this, and can I pass it on to my kids? And certainly there was a paper that just came out in Nature to suggest that there is an inherited predisposition, not of the JAK2 mutation, but just of a tendency to get mutations that lead to MPN. So that's been another huge advance in the field. So it'll allow us to watch out for families, watch out for individuals who may be at risk in the very same way that we do for breast cancer for people who have the BRCA1 or 2 mutation. So I think that's a major advance.
Okay, great. So getting back, you know, I'd like to start with this since it's on everybody's mind. As I said in the opening, many of the physicians that have been in several of our events so far this year have highly recommended as soon as the vaccine is available for our patients to get that vaccine, not to be afraid of it. Could both of you speak to that for a moment, please? And just, I guess my question would be, do you recommend it, you know, with your colleagues that have said yes? But also, you know, do you feel comfortable with whatever one comes out of the chute first, that is the one we all should get, but primarily our MPN patients?
I can say what, from my standpoint, what my opinion is, at least. So I think, you know, we got big news this week that Pfizer and Moderna are both have both or are both applying for or have submitted their applications for FDA approval of their respective vaccines, which is really exciting. And we've gotten so much news over the last couple of weeks from these first 3 vaccines that are furthest along in development, from Moderna, Pfizer, and AstraZeneca, that the efficacy seems to be quite good. And from what we're told, there haven't really been any safety signals or any really concerning toxicities. Of course, it's been in the short term. These vaccines haven't been around for very long, obviously, and many people have asked me, am I concerned that this is being rushed? And in some ways, yes, it is being rushed. Vaccine development usually does take a number of years, not months, but it needs to be rushed right now. Obviously, we're in a place right now as a country where we need to do something fast as possible to get control over this virus. So I think from the data that's been presented and been made publicly available so far, I think all 3 of these vaccines seem quite effective. We were all hoping for at least 50% efficacy, and we're hearing numbers of anywhere from 70% with 1 dose of the AstraZeneca vaccine up to 95% efficacy with some of the others. So I think those were numbers that I think everyone can say that they're very pleasantly surprised to see that good news come out very recently. So I think we'll have to see what the FDA says after they sort through the very detailed safety information that they're gathering right now from the tens of thousands of folks who have participated in these vaccine trials so far. But from what we know and from everything that I've read and heard so far, I am very much expecting these vaccines to be very safe and very efficacious. So I can tell you from my standpoint, I'm in line at our university already to be receiving one. And I've been recommending to my patients that they strongly consider it too once they come out. But also, I do think it's fair to potentially wait to make the decision until the FDA makes their final decision first. You know, they have everyone's best interests at heart. And I do agree with what Ann said too, that those with, or I'm sorry, maybe Dr. Jamieson said this, I forgot who said this, that those with compromised immune systems haven't necessarily been a huge part of these clinical trials so far. So I think that that is an ongoing question for all of us, as well as folks who are older or folks who are much younger too. Most of these studies have not included a large pediatric population. So I think there's a lot more questions than answers right now, but I think it's all exciting news, and I think I'm looking forward to getting my vaccine, and I'm recommending that most of my friends, families, and patients do the same.
Yeah,
Dr. Jamieson, go ahead.
And I'm just sitting right across from the Salk. I'm literally looking at the building from my office here, and it just reminds me of how important a massive vaccine campaign is. Of course, that led to the eradication of polio. And so here we have a similar sort of thing where herd immunity really matters. We're only going to get that if we actually all get vaccinated. So starting with healthcare workers, we're all going to get vaccinated en masse. So that means that we're going to see if there are other side effects that we couldn't have predicted from clinical trials. Healthcare workers have varying levels of immunity themselves. Some have had their own issues with health issues or health problems. So I think we'll get a better view of what the side effects are going to be. Here, we're planning to get vaccinated, all the healthcare workers in our system before the end of December, at least for the first dose, and this second dose comes 3 weeks later. Pfizer and Moderna look to be very similar, and AstraZeneca is kind of catching up. There were some side effects from that AstraZeneca virus or vaccine, so we're looking to see what transpires with that. But as Kristen was pointing out, the FDA is really quite circumspect and extremely careful, and I think they'll really pour over any potential side effects. I'm expecting that there will be a fever for people to get the vaccine, maybe attenuated slightly in people who are on a JAK2 inhibitor. So we have to look at the impact of JAK2 inhibition on the response to the vaccine. And Jakafi inhibits both JAK1 and JAK2. JAK1 inhibits T cells, so there may not be as robust a response to the vaccine. So that's something to keep in mind. Inrebic doesn't really inhibit T cells other than T helper Th17 response style T cells, so I don't think that'll be as much of an issue. But what about people on Pegasus? They may have a boosted immune response in the setting of getting additional interferon, which is what Pegasus is. So I think we have to keep an open mind for what the responses details will be. But overall, it looks like a very safe vaccine from the studies that have been done to date. And I think that we'll be moving ahead fairly quickly to get the population vaccinated. And we'll do this under controlled circumstances in our academic medical centers for people with myeloproliferative neoplasms. And we're really looking forward to offering that together with testing and together with family members, you know, that family members get tested just like we've done for the testing protocols. We have everyone tested. If we have a visitor in our system, they're COVID tested. So I think that's a way to keep everyone safe.
Great follow-up question here, which I think is very pertinent, and then we can wrap up the COVID conversation because we got a ton of questions, which I knew we would. And that is, who will be gathering this information or monitoring any side effects that MPN patients have that are specific to any of these vaccines, and you know, to whom should they send these subjective symptoms and clinical data to, if somebody in fact is doing this?
And I'll interject on that one. Like any post-marketing analysis, once these vaccines get approval, you can still report side effects to the company that distributes the therapy. And in this case, it's a vaccine. So it's a preventive strategy. So the company would still get all of the adverse events. And if people have a fever, they can reach out to Pfizer, reach out to Moderna. Once AstraZeneca gets approved, same thing, reach out to them. And this is how we've done it for the JAK2 inhibitors for MPNs with Insight Cares. If people have side effects to Jakafi, or in other words, ruxolitinib, they can reach out to the manufacturer and say, hey, I had a side effect. So it's going to be the same thing. I think it would be good for those of us in the MPN community as researchers and physicians to actually keep track of any potential side effects that may be different in people with MPNs based on whether they're getting treated or not. Certainly there's a larger push to do that for patients with cancer who have COVID, and there's a national registry for that. But it doesn't focus on MPNs per se. So maybe something that the MPN Advocacy Group and Research Foundation together want to work towards. We certainly have the capacity to track patients and their outcomes in our individual centers. And I'm sure Kristen has an opportunity to do that in Michigan.
Yes, yeah, I completely agree with all of that. Yeah, I think going any toxicities or side effects, initially reporting those, either you or your physician can report those to the company, who will continue to keep an eye on these post-marketing experiences and continue to, they have a requirement and an obligation to continue to report these back to the FDA even after these are approved. So that will probably be the major way that these are followed over time. But I completely agree with that that idea that Dr. Jamieson had that we should be coordinating as an MPN community. As far as I know, nothing formal has been done there before, but or up to this point at least. It's still early with these not being approved yet or available yet. But I do think we should start talking about that, about ways to monitor for these side effects in our MPN patients. Here at the University of Michigan, we're going to be monitoring all of our patients with all different disorders. Our infectious disease group here is absolutely phenomenal, and they already have a group coordinated to monitor everyone who will be getting vaccines, probably first healthcare workers, and then shortly after that, other at-risk populations. So I know within our institution, we have a way to do that already, but it would be good to join forces around the country to do this for folks with MPNs for sure. Excellent question and suggestion.
Yeah, I agree. I think it is a good suggestion. So let's move on. We have lots of questions for you. First question, how effective is, I may be pronouncing this incorrectly, is it Jednu? It's in reducing high ferritin levels. It's a chronic iron overload medicine due to transfusions.
Yeah, Jednu and XJ, they're essentially the same drug. Jednu and XJ, they're just formulated slightly differently, and they can both be effective provided they're taken properly. I think the biggest issue with these iron chelators is they can affect kidney function, and so we have to be careful with that. And in some people, they have an elevation in liver enzymes. Theoretically, they can make cataracts worse and induce hearing problems. I've actually never seen that, and I've given a lot of this medication, which can be extremely effective over time in terms of reducing iron overload. But I would also suggest there's a new medication that's undergoing clinical trials for myelofibrosis and has already been approved for myelodysplastic syndrome with ring sideroblasts and anemia related to that, and that's called luspatercept or Reblozyl. So the reason people get iron overloaded very commonly with myelofibrosis is because they become red blood cell transfusion dependent. If we can reduce the need for red blood cell transfusions with these newer medications like Reblozyl, we may be able to reduce iron overload. So I think now what we're trying to do is a dual-pronged strategy where we give Reblozyl as an injection every 3 weeks, and then we also lower iron using an iron chelator. I find XJADE's a little easier to give. It's 20 milligrams per kilogram daily, and I usually start at a slightly lower dose than that just to make sure people tolerate it because of the potential for drug-drug interactions with medications that treat myelofibrosis.
Yeah, I agree with all of that was said too. It's one of those things where an ounce of prevention goes a long way. If we're able to avoid red blood cell transfusions, that's the best way to avoid the problem of iron overload over time. Of course, that's much easier said than done, and I hope we have newer agents, newer medications to promote red blood cell maturation and red blood cell production in folks with myelofibrosis over time. We're using a lot of luspatercepts here as well. You know, we have things like Aranesp and those EPO types of agents to try to help red blood cell production. Then we have this new luspatercept agent that Dr. Jamieson was speaking of, which we're using a lot of here. We can also use things like danazol. We have a few other things up our sleeve to try to decrease transfusion requirements. And then I think one of the most interesting things coming up that's still in clinical trials, still investigational, is the medication CPI 0610 from Constellation, which is called a BET inhibitor, which also works by decreasing inflammation in the body and promoting red blood cell production and maturation. So there have been, I think, encouraging results up to this point of using that drug both by itself and in combination with ruxolitinib to try to improve responses in patients with myelofibrosis, spleen responses and symptom responses, as well as anemia responses. And I think those anemia responses are potentially the most exciting part of that drug and other drugs in that class of BET inhibitors that are coming up. So I think the iron chelators, there's certainly a role for them, but as Dr. Jamieson nicely pointed out, they're not perfect. They have some potential toxicities, and it's often hard to kind of balance the risks and the benefits of the drugs when we're talking about patients who are on a lot of other medications and may have some issues with their kidneys or liver or GI tract to start out with. So they're not perfect, and anything we can do to decrease the need for red cell transfusions should be our focus, I think.
So moving right along, we always get this question, and I knew we would today, and that is, could you discuss the benefits and risks of hydroxyurea?
Well, hydroxyurea.
Go ahead.
Yeah, sorry, and there's a little bit of a delay. Yeah, so hydroxyurea is an excellent medication for people with polycythemia vera, as we saw from the CYTO-PV study published by Tiziana Barbuti and colleagues, in the sense that it decreases cardiovascular events and strokes. We don't want the hemoglobin to be over 15, so it's an excellent medication to prevent that for people that do not respond to phlebotomies alone. And that's a very common situation where people do not respond to phlebotomies alone. I think the theoretical risk is there was a slight increase in cases of leukemia on hydroxyurea. They weren't considered to be statistically significant, but we always worry about long-term exposure to something that affects the bone marrow overall. Nonetheless, the decrease in mortality from strokes and heart attacks on hydroxyurea is something to be really impressed by, I think. That study was such a positive study. It was published in the New England Journal over 5 years ago now. that the Italian government had to stop the study because survival was so much higher in the hydroxyurea and phlebotomy group than in the group where they let the hemoglobin go too high. So the real area of controversy isn't about polycythemia vera, it's more about essential thrombocythemia and when do we reduce the platelet count in essential thrombocythemia. And I think a lot of people are told they're not symptomatic, but they really haven't had a very thorough symptom assessment in the way that Dr. Mesa would do it. So you really have to ask about vascular events, numbness in a fingertip or toe. It's not just general paresthesias. It's one finger, one toe go numb. People have severe headaches, things like that. I think we need to be more cognizant of some of the symptoms of essential thrombocythemia and treat not based on age, but based on symptoms. So I think hydroxyurea is a very safe drug. We've used it for sickle cell anemia for at least a couple of decades, and it's proven to be safe in that situation. Again, I do monitor by next generation sequencing to see if people are acquiring other DNA mutations. So I think that's how we'll continue to keep people safe while they're on hydroxyurea. And the question I get more frequently now is, should I be on Pegasus instead of hydroxyurea? Because that's very safe. It controls the blood counts. I use that in pregnant women. It has its own side effects. It can cause an increase in liver enzymes that's more autoimmune. It can cause depression. And I see that as a dose-dependent response. So we just have to be careful with every medication and just remember that they all have their unique side effects. But I think hydroxyurea is an excellent choice for people with polycythemia vera to keep their hemoglobin or hematocrit in a reasonable range.
Kristen, did you want to add anything to that?
I think that was perfectly said. I really don't have anything to add to that. That's exactly what I would say.
Then I will go to this question, which is a little bit different, but about hydroxyurea. Recently, my hematologist recommended I go off hydroxyurea. He stated it has shown no benefit for triple negative with no history of clots. This person is 72 years old and at intermediate risk. Do you have anything to say to that? Either of you can go first.
Yeah, so this is Kat. Sorry, Kristen, I'll let you go first next time. I think as we get older, our risk of having a stroke or a heart attack just goes up. Just by statistics, you know, as we get older, we become more hypercoagulable because of Virchow's triad: endothelial injury, hypercoagulability, and stasis. So stasis meaning we don't move very much as we get older. We tend to have more areas of injury in the blood vessel wall, often from hypertension that is long-standing, and then which gets worse as we get older. And then hypercoagulability, you know, that can happen if you have another low-grade malignancy, or an MPN itself causes this capacity to clot. So I'm very, very careful about taking people off hydroxyurea, especially when they're 72. They're at increased risk for clotting, and I would say that's probably the population that derives the most benefit. If they've got intermediate 1 myelofibrosis, the real question is, should they be on something other than hydroxyurea? Should they be on a JAK2 inhibitor? The triple negative group, you know, the JAK2 mutation needs to be confirmed in a bone marrow biopsy, because I've got a couple of patients who are JAK2 mutation positive or calreticulin positive in the bone marrow, but not in the blood. And that is a low variant allele fraction or frequency kind of population, but certainly something I would suggest be tested. 72 is not old. I've got somebody who's 96 in my clinic who's getting treated. And he said, how long should we be doing this? My mitochondria are tired. And I said, if you're tired about your mitochondria, we're going to keep treating you. So he's happy to be treated with a JAK2 inhibitor. You know, the triple negative population is turning into a very interesting group, where they may be negative for an MPL mutation, JAK2 mutation, or CalR mutation, but often they have other mutations that may respond to the very inhibitor that Kristen talked about. This is the BET inhibitor to reduce overall inflammation. And I'd really want to see, is this person somebody who would be eligible for a clinical trial for a BET inhibitor, which is a pill, by the way, combined with a JAK2 inhibitor. So I think that would be what I'd want to ask that person.
Hello, just jumping in here between multiple conflicting meetings for a while, but excited to join this fireside chat with my good friends, Dr. Pettit and Jamieson.
Hi, Dr.
Hi,
Mesa. We're glad to see you. You look tired. I mean, you've been under a lot of stress.
Yeah.
I will be glad when this era of the pandemic is over. This is my 10th activity today so far.
Oh my gosh. Oh my gosh.
You know,
Well,
so
we can't thank you enough for joining us.
No, delighted to be here. But I think the pandemic has, what it's done is it's taken out all of the buffer of life, and it's just this distilled workflow that is unsustainable.
I completely agree, and I am nowhere near at the level of stress that the three of you are at. So I so greatly appreciate you being here and doing this. And if you don't mind, I'll move on to the next question. But we, you know, Dr. Mesa and the three of you know that at most of our events we get so many questions, and these conversations with the specialists have just been amazingly well attended, and people have lots of questions. We're shocked by some of them because we forget that there are new patients out there, or patients that are not connected to the resources available to them. And for example, one of the questions we get frequently is about the allele burden, and does it matter what a person's allele burden is? And so could the three of you, and I guess we'll start with Dr. Mesa, answer that question or talk to discuss.
I think a bit of historical context for folks. The allele burden in a very different disease, chronic myeloid leukemia, was found to be a very useful marker of disease, where they measure a protein that's not normally present in the body called BCR-ABL. And with therapy for CML, they're able to lower an allele burden of, let's say, 80% down to 0.001%. So a dramatic decrease in that allele burden. And with that improvement in allele burden corresponds to things that are meaningful: the patients being under better control, the complete remission, lower likelihood of the disease progressing. Since the beginning, people have wanted to try to make JAK2 V617F allele burden into something similar to that experience with BCR-ABL. I will be honest, I don't think that it is. It is not clear that measuring that allele burden has been as helpful as it has been in CML. Now, there may be two reasons for that. One, that JAK2 may not be the most crucial initiating step in MPNs for us to track. Or two, we have not lowered the JAK2 allele burden as dramatically as we do in CML, and then maybe it is less helpful. So at the moment, I can't say that the allele burden, other than being a number that we can look at and say, boy, that's nice that it came down, but we've really not been able to correspond that to people living longer or people living better lives.
Kristen, would you like to add anything to that?
Sure, of course, as always, I completely agree with everything that Dr. Mesa said. I think it's a little controversial, and I think more time will tell. We don't routinely, on a routine clinical basis, necessarily follow allele burden here for our patients. We do as part of clinical trials, certainly, to learn more about the implications of the allele burden, but for many of our patients, we're not necessarily getting that information because we don't know what to do with it. So I know every institution manages that a little bit differently. Here in our group, we don't necessarily follow it outside of a clinical trial setting. One thing that is interesting is to look at these clinical trials and what people are starting to report for some of these newer medications that are being developed over the last year or two, that seem to have some clinical activity for patients with myelofibrosis. And now some of these trials are just starting to report on effects of those allele burdens. So at ASH this year, I'll be reporting on some of that for one of the drugs that we're studying, which is called bomedemstat, or IMG 7289, which is an LSD1 inhibitor. It's an epigenetic therapy, oral medication that really targets the megakaryocyte, the cell that produces the platelets in the bone marrow, and likely drives a lot of the fibrosis and inflammation in the disease. And we did see some decreases in some allele burdens, but it depends on which specific gene you're talking about. If you're talking about the JAK2 mutation, if you're talking about one of the other mutations, for example, things like ASXL1 that we see frequently mutated in these disorders. So oftentimes we can have kind of subclones in these diseases, that not every cell has exactly the same genetic makeup or genetic mutation complement. So it'll be interesting to see over time how different drugs affect different clones that are there in the bone marrow or the blood, and how important or not important that change in allele frequency is over time. I think it's an open question still.
Yeah, and I agree, Kristen. I think, we showed that the JAK2 mutation occurs at the level of the hematopoietic stem cell quite a few years ago now, 14 years ago. And I remember at the time when the 4 groups discovered the JAK2 V617F mutation, people said, well, why test for it? We don't know what to do with it. And within 2 years of that, we had JAK2 inhibitors that I do believe have changed not only the quality of life for people with MPNs, but quantity of life. People are surviving longer. So there's got to be something to reducing inflammation at the very least. But just to echo what you've been saying, Kristen, and what Ruben was saying, we really don't know with more effective strategies whether or not we're going to decrease the burden, not just of the JAK2 mutation. When we say allele, we suggest that you're mutating one copy of the JAK2 gene, and that's what we mean by mutant allele burden. We also say variant allele fraction or frequency. What percentage do you have? So it's only recently that we started actually measuring the percentage. We did that for a long time. We did it for 10 years in CML before we all agreed, okay, maybe it does make a difference. Now we have quantitative tests that allow us to quantify the level of the JAK2 mutation, and as you were suggesting, Kristen, the other mutations as well, ASXL1, TET2, DNMT3A, other higher risk alleles like IDH1 and IDH2, those mutations need to be followed. Those people are likely to be at increased risk of transforming to acute leukemia. So I do this in every single patient because it's an in-house test for us. And I do think it's a research question at the moment, but hopefully it'll be something that we're able to offer our patients and be able to prognosticate based on mutation status, and also looking at, as I mentioned earlier, RNA changes and things like that. Whether or not we'll have to get to the level of long-lived stem cells will be something that we're, I mentioned earlier, and may be possible with advances in technology. But I think that we can monitor this and stay open-minded with these combination strategies to see if they're more effective at decreasing not just the JAK2 mutation, JAK2 V617F, but these other higher risk mutations like ASXL1. And that's something I think we can do as a community.
Thank you, Catriona. So the next question for the 3 of you is, if the hematocrit value reaches a steady state for polycythemia vera patients, in this case for almost 10 months, does that signify anything? And this person has received varying opinions from different medical people. Dr. Mesa?
So one that clearly is one of the goals, so what are our goals as we're treating polycythemia vera? There's agreement through the European Leukemia Net and the US NCCN guidelines that both Catriona and I helped to develop, that the goals in PV are to try to keep the disease as invisible in your life as possible. And that includes trying to protect you against blood clots and bleeding, but also being mindful of the therapy, and hopefully that the therapy is not harming you in an adverse way in terms of daily side effects, etc. In terms of the goals with numbers, the current goals are to ideally have a hematocrit under 45%, and for some of you it may be lower than that based on how you feel, etc., but at least under 45%, a white count under 10,000, and a platelet count under 400,000. So I would say that a stable, hematocrit is clearly one of the goals. Not necessarily the only goal. It depends on how someone feels and other things. But it is not uncommon in Vera to get to a steady state where if it's through phlebotomy alone, the amount of iron deficiency balances the overdrive of creating too many red cells from the Polycythemia vera, and individuals can stay at a steady state without needing phlebotomies. For some individuals, that is a stable place to be, but it would depend as well on how an individual felt.
Drs. Pettit or Jamieson, would you like to add anything to that?
Sure, I completely agree that the number is an important part of the puzzle with Polycythemia vera, but as Dr. Mesa said, the number is just one piece. And I think the way that that you're feeling overall, as far as any side effects from the medications that you're on, or any persistent symptoms from the MPN that might still be there, despite having good control over that number, those are the other important pieces to keep an eye on. But I think it certainly sounds like a good thing that the number has been so well controlled for so long, and that's certainly one of the several goals in this disease.
Yeah, and of course, I agree with both comments. When you look at the cardiovascular events and intensity of treatment in polycythemia vera that was published in 2013 in January, just after the American Society of Hematology meeting, it was clear that people that were able to sustainably keep their hematocrit less than 45%, as Ruben was mentioning, do better. They had a significantly lower rate of cardiovascular death and major thrombosis than did those with a hematocrit target of 45% to 50%. And that was funded by the Italian medicines agencies. So you don't just stop when you get to a good level, I would say. They didn't just stop treating people to keep to a hematocrit of less than 45% when people got to that level. Just like with hypertension, we don't just stop when people get to less than 140/90. I think the key is when people start to notice their hemoglobin drop without phlebotomy, without hydroxyurea, and they start to get night sweats, they start to get pruritus. This is something that Dr. Mesa and I were very cognizant of when he insisted that we start the MPN panel for the National Comprehensive Cancer Network, that we have to watch to make sure that the disease hasn't progressed to myelofibrosis. And I think that's the key. If people just find, hey, I don't need phlebotomies anymore, I don't need hydroxyurea anymore, and in fact, my hemoglobin's quite a bit lower. It's at 11 instead of 14 or 15, and that's even in the absence of phlebotomy. So that's really what I watch out for in people.
And we, of course, we get a lot of questions about interferon. And one patient has asked or has stated they've been on interferon for 12 years and now have to go off. And number one, what should they expect? But number two, what are your opinions about the new interferons that might be coming available in the next year or so? And just your opinions in general about. Dr. Jamieson, do you want to just start and we'll go counterclockwise here?
This is something that Dr. Mesa, our friend Ruben, is absolutely the world expert on, so I defer to Ruben. I've just been very impressed by how effective interferon is, not just on its own, but in combination with JAK2 inhibitors. And, that's something that I'm very encouraged by in terms of reducing the symptoms of myelofibrosis in particular. In terms of interferon for polycythemia vera, it's very safe. I think the key is it's kind of hard to get for some people. And when we talk about the other interferons, it's really based on clinical trials or availability in Europe as opposed to in the US. The most common type of interferon that we're using here, pegylated interferon, polyethylene glycol is just a tag we put on interferon, or the drug maker Roche puts on interferon to make it last longer so people have fewer side effects. That's one that is very, very well tolerated. And I mentioned before, I just watched for liver enzyme increases in depression. The real question is, why is the person coming off interferon? Did they have a side effect? What's the issue, and what other medications are they going to consider? But I've been very impressed by the sustainability of responses to Pegasus, and I'll defer to Dr. Mesa on the other types of interferon.
Dr. Mesa.
To jump in there, so we have the Pegasus that many on the call have been on, which is pegylated interferon alpha 2A, and the one that is in discussion as the alternative is rho-pegylated interferon alpha 2B. And when we speak of interferons having benefit for patients with MPNs, both kind of the short-acting interferons, ones that don't have pegylation. Pegylation is the addition of a molecule onto interferon so that it lasts in your system longer, so that you can get dosing less frequency. So the old short-acting interferons people took daily or more than once a day, as opposed to once a week for Pegasus or once every 2 weeks with rho-pegylated interferon. But they have all overlap significantly in terms of effectiveness. So they all can be effective. They have not been directly compared against one another. Where they may vary is in terms of side effects. The long-acting interferons, both Pegasus and rho-pegylated interferon, likely have significant side effect benefits over the short-acting interferons. The rho-pegylated interferon alpha 2B is a slightly different molecule. It has some chemical advantages potentially in that it is there's only one isomer of the molecule, which might lead to less side effects. It certainly is dosed less frequently. We don't have direct studies to compare rho-pegylated interferon to Pegasus. So we can't say for certain that it has less side effects, but it seems possible that it might. Certainly nothing from the clinical trials would lead to any concern that it has a higher rate of side effects. Likewise, the clinical trial data looks just as favorable in terms of effectiveness. So we don't think that there'd be any reason that it would be less effective. It might be more effective, but I can't say that we have proof of that yet and no direct comparison. By far, the most important difference is that if rho-pegylated interferon becomes approved, and it is not approved in the US yet for any reason, it will likely be much easier for MPN patients to be able to obtain interferon with less barriers from their insurance companies or others than they experience with Pegasus, because it would be approved for the disease. So that would have the most practical implications. But I am very excited both by the efforts of AOP and Pharmacentric to try to develop the drug. I think it's a good drug. I think getting it prescribed and labeled for MPNs will be important both in dealing with insurance companies, but even stuff such as education of physicians in terms of using it, and even packaging. So many of you on Pegasus are probably having to either discard part of the medication you receive because it's prepackaged for a different reason, like hepatitis C. in many ways that are suboptimal. So I would envision a MPN specifically labeled drug with the ability to dial in the dose exactly for what you need, and have both your nurses, your pharmacists, your hematologists kind of appropriately instructed on its use, its care, and its use in MPNs. All of that, I think, would really be quite a bit better than the current state. Because what we have at the moment is there's many people on interferon, but it's all a little bit awkward because the insurance companies aren't necessarily on board. Your local physicians aren't very familiar with the drug. So I do envision that could be a very important move forward.
Kristen, would you like to add anything to that, or is that pretty well stated?
That's pretty well stated. I don't have much to add, but yeah, I agree with everything that was said, though. I think as far as logistics go, and I like that Dr. Mesa described the current PEG interferon as awkward, because I've used that same description for with some of my patients before. It's a little bit difficult and cumbersome to obtain oftentimes, and that's often one of the limiting factors of pegylated interferon that's available right now. So I think the RO-PEG interferon is exciting in terms of maybe efficacy. I think at least efficacy compared to historical rates with pegylated interferon. I think probably in terms of toxicity, and then definitely in terms of obtainability and logistics if and when it becomes approved in the US.
Okay, thank you, the three of you. Thank you very much. And so moving along, we hear a lot about progression, and some patients are curious. You know, they've had an MPN for quite a few years, and in your opinions and from the work that you do and the patients that you see, does every patient progress to something else, or can patients live a long life with polycythemia vera or ET and nothing changes and it pretty much stays the same? Could you speak to that? And Kristen, we'll start with you, please.
Oh, sorry, there's a little delay. Yeah, of course. Yeah, so I think to take a step back, in some ways it depends on the disease that we're talking about, whether we're talking about ET, PV, overt myelofibrosis, or pre-fibrotic, an earlier phase of myelofibrosis. Each one of those disease states certainly has a different chance, a different risk of progressing over time. And I think the other thing to think about is what we mean in terms of progression. I think there's a few things that can happen with these diseases over time. They can progress in terms of becoming more symptomatic to an individual, having more of these constitutional symptoms like fevers, chills, night sweats, weight loss, appetite changes, all of those kinds of things. Splenomegaly can be one mechanism of progression as well, if the spleen or liver start to grow and cause more problems. There can be the progression to myelofibrosis if we're dealing with ET or PV to start out with, or to a more advanced phase of myelofibrosis over time. And with those conditions, what we typically see with that form of progression would be lowering of the blood counts, any of the blood counts, the white blood cells, the hemoglobin, or the platelets, potentially into ranges requiring blood or platelet transfusions or putting someone at risk for things like infections. And then the last form of progression would be an actual change in the disease towards something like an acute leukemia, which is a more aggressively behaving bone marrow disorder, of course. So we have various different tools to try to predict the risks of progression based on what the disease is to start out with, what the mutation profile is to start out with. I think Dr. Jamieson mentioned earlier the MIPS score that takes into account blood counts, the chromosome findings, and the individual genetic mutations. So we do our best to develop a crystal ball to try to predict what the chances are and try to give people the best possible expectation that we can come up with as far as the risk of progression to either a myelofibrosis or an acute leukemia over time. But I think one important point to remember is if we're dealing with ET or PV initially, the most likely thing to happen in terms of progression in the short term is nothing. I think the risk of transformation right to an acute leukemia from ET or PV is very low and very rare, although we do watch for it every time blood counts are drawn. And risk of progression to myelofibrosis is there, but again, it's not something that generally happens overnight. It's usually a slow, stepwise thing, and it is very possible that these diseases will never progress over the course of someone's life, and we will just need to continue to monitor for that, continue to monitor a patient's symptoms, and to focus on quality of life as best we can with our treatments.
Dr. Mesa? Or Jamieson? Oh, there you are.
No, my apologies. I think very well said by Dr. Pettit. One thing I would add, the way to look at these diseases is as diseases of plateau or potential periods of progression, meaning they're not diseases where things progress on a daily or weekly or monthly basis. You know, I have many patients that are, you know, very sophisticated mathematicians, scientists, engineers. You know, they come and they try to bring me information in the graphical form. You know, change in blood counts, change in spleen size. You know, some are even sophisticated enough to derive the mathematical equation of the rate of change. You know, and biology just isn't that way. And the biology with these diseases, and it's very clear, having seen many thousands of patients over the years, is there's periods of stability and there's periods where things can change. And what we don't really know yet is why do they change? And what can we do to avoid that change? There are certain clues, JAK inhibitors, interferons, some of these things may perhaps have favorable ways of trying to push against change, maybe even drugs like azacitidine or decitabine on the acute leukemia side. But not everyone will progress. People can be in long plateaus. Some people can be in decades-long plateaus, some even without medical therapy. And what the difference is between those individuals, we still don't know. But if we could answer one key scientific question, it would be, why do MPN patients progress? Because if we knew that, we might be able to not only design better medicines to either avoid progression or cure the disease, but we would also be able to better predict or monitor who is likely to progress. So in the individual that we start on pegylated interferon in the hopes that we help to avoid progression, we don't truly know whether we're avoiding progression for that patient. We hope we are, but we don't know whether we have achieved that as long as we don't see them progress. So more for us to learn, but it is an area of tremendous scrutiny. I know scientifically it's an area of focus that they are encouraging and supporting research through the MPN Research Foundation.
And this is Catriona. I fundamentally, wholeheartedly agree, as usual, with Dr. Mesa and with Dr. Pettit. I think that this is the key for the field. I have people in my clinic, I've had a clinic here at UC San Diego for 14 years who haven't progressed. They should have progressed, but they didn't. So, and that's just based on their JAK2 mutant allele burden. So what is it that makes some people progress to higher levels of myelofibrosis, more advanced disease, or to acute leukemia ultimately? I've had other people who have progressed to acute leukemia very quickly. So is there some modifiable risk factor? And, you know, I think that the interesting thing is it looks like DNA is not destiny. Just having the JAK2 mutation, the calreticulin mutation, the MPL mutation, or even an ASXL1 mutation doesn't mean you're necessarily going to progress. So I think there are other features that promote disease progression, and that includes inflammation, and that's because inflammation can drive activation of enzymes that actually mutate DNA and/or RNA. And this is, I think, a really important new finding in the field that suggests that if we reduce inflammation, we may actually prevent further mutations from being made by these enzymes called ApoBex and other enzymes called ADAR, ADAR1, and those are DNA and RNA mutators respectively. The good news there is we can reduce the activity of those enzymes with anti-inflammatory drugs. And so while that may seem heretical, what it suggests is if we reduce inflammation, we enhance our capacity to do exercise, circulate the lymphatics, have our T cells actually recognize these cells as foreign by having a robust immune system. I think those are key aspects of care. And I think that's why actually Pegasus is so effective. It actually enhances immune responses against these rogue pre-malignant clones. Also, I think we need to look at the immune status for a number of people with MPNs. Is it that they make more mutations, or is it that their system, their body, their immune system just doesn't recognize these mutated cells as foreign? And I think that's where the field is going to go in terms of understanding, should we be boosting natural killer cell capacity to recognize these cells as foreign? And should we be giving people, things that boost immune responses? And, that's, I think, an open part of the field that we'll be looking at. But, I think there's so much going on scientifically, and we'll be able to say more definitively in a couple of years why some people progress. There is a group in the UK that's looking at whether people have the propensity to get these diseases from birth, and not everybody progresses. And similarly at Harvard, the same sort of situation has come about. So it means that there are some environmental drivers of progression, and we're keen to look at that with Dr. Mesa and move these studies ahead. Just interestingly, we're also working with NASA. We just got a fairly large grant from NASA to study pre-malignant changes in the blood and immune dysfunction in low Earth orbit, because there's a higher level of ionizing radiation and exposure to inflammation-inducing agents that may allow us to look at bone marrow aging in an accelerated time frame. So that's something that we're just embarking on, and that will launch next March, hopefully. But, obviously a number of people are interested in bone marrow failure syndromes and trying to find mitigation strategies. So I think the field, the MPN field, is actually leading the charge on that.
Everything sounds
my takeaway is that it's pretty cool that Dr. Jamieson has worked with NASA. Pretty cool.
I think it's fantastic.
All sorts of lingo. And the one thing they said is, I was on this Ascend meeting, which is the Association for Aeronautical Engineers, feeling completely like a fish out of water. And, we had stem cell biologists and then this NASA healthcare economist, actually. And he said, you guys are newbies to space. And we said, oh, sorry, can you hear me?
Yeah.
Hello? Yeah. Anyway, he said, you're new to space, and we said, you're new to stem cells. And then the other person who's a stem cell biologist said, Kat, don't you agree that what is really common here with both of our fields is nerdiness? And I said, no, I've risen to a different level. It's being a geek, which is the highest level of nerdiness. It's like nirvana. But anyway, I think we're able to look at things from a completely different perspective and use all the NASA tools to analyze stem cell aging in space, not just in the blood, but also in liver organoids and brain organoids.
I would be very happy to volunteer for any trial that you have in space at the moment.
There may be an opportunity. I think Ruben gets first dibs.
So moving along, two questions that we get asked frequently as well, but they're here and these individuals are watching and listening, so we must ask. And that is, what are your opinions and what do you know about Crispr? And then we'll move on to the next question. Who would like to start?
And this is Kat, sorry to interject again, but this is what I was alluding to with the APOBEX and ADAR enzymes. These are our own CRISPRs. What are CRISPRs? These are enzymes that bacteria have to prevent them from being infected by viruses. So viruses for bacteria are called bacteriophage. And so Jennifer Doudna and Emmanuel Charpentier just got the Nobel Prize this year for discovering how to use those CRISPRs to create very specific changes in our DNA, and they're very specific changes, but unfortunately there can be some off-target effects. So where the field has moved to is using these base editing enzymes, APOBEC and ADAR, and just use the editing piece of those enzymes attached to the Cas protein, so that the editing is even more precise. So with that base editing technology, we may be able to change that JAK2 V617F. It's a point mutation that leads to the change in valine to phenylalanine at position 617, that amino acid. That's potentially doable. There still will be some off-target effects. So the question is, how safe is it? And how much safer is it to use CRISPR-style technology to eradicate the mutation, or at least lower the burden of disease in the person, and then hopefully decrease progression? And that comes back to Dr. Mesa's point, is we don't know how low a JAK2 mutant allele burden is sufficient to prevent progression. And, you know, it's certainly an open question. I think we have the technology at hand to be able to start testing this. But it goes right back to our bone marrow transplant days. You know, I trained as a bone marrow transplanter not once, but twice. And basically, we could get down to a lower level of mutation and not have people show technical signs of relapse for their AML, if they were AML1 EDO positive, for example, or for chronic myeloid leukemia, if they were BCR-ABL low, not negative. So I think people can live with a low burden of disease and not necessarily progress, provided their immune system stays healthy. So I think it's an open question. I think you'll see that in upcoming clinical trials. It will really be more of a safety issue. How safe is the technology? We have a Deaminate meeting coming up in January. Where we'll discuss the base editing technology, both APOBEC-driven and ADAR-driven, because in the human system, as opposed to in mice or other organisms, we have to be a little bit more careful about editing genes that weren't mutated to begin with. And that's going to be the major technical challenge for the field.
Dr. Pettit?
Yeah, I think that was beautifully said. I don't have much else to add other than, yeah, I think the safety concerns will be the biggest thing to see, both in the short term and the long term with CRISPR technology. And it'll be interesting to see also efficacy-wise, kind of balancing the efficacy and the safety, whether it's necessary and effective to actually edit the genes, or whether just inhibiting the downstream effects of those gene mutations. So through maybe combinations of JAK inhibitors and other drugs that are being studied right now, whether that might be effective enough way for most patients to prevent progression and to control the disease. But it will be an interesting next few years, that's for sure.
Dr. Mesa?
So very eloquent answers that you had heard. You know, I think it's very tough to watch the sausage being made. You know, so I'm very mindful. You know, I'm very mindful for patients that, you know, the scientific process is tough to watch when it's so important to your situation. You know, I think that there is a big gap, I think, between where we are now and, you know, and CRISPR being an active therapy. And there are the reasons that Dr. Jamieson had mentioned, but there's another level. We know that there's a lot more going on in most individuals than just one genetic change. So there's many individuals that have other somatic mutations, even that we know of, and there's a possibility of other mutations that we don't know of. So even if we said that we could correct, let's say, the JAK2 V617F mutation, does that take away the disease? I don't think we know that. If an individual has that mutation and other mutations, would we need to inhibit correct the other mutations as well? So I think there's a lot of things to be worked out. And I'm very hopeful that we will continue to learn more. A lot of the good news is that this does not have to only be figured out just for MPN patients. The research being done in this broader area of gene therapy is all being done in parallel. But I think it's important just to know the complexity of this is daunting, because there's probably more than one switch that has to be turned on or off for most individuals that face these diseases.
Next question, which we discussed at a previous program, and I'm going to start with Dr. Mesa because I know you do have to leave at 1 o'clock, and that is what clinical trials are going on right now that you're involved in and want to discuss, but also what looks promising in the pipeline and promising for what group of patients, PV, ET, or MF?
It's an excellent question. And first, there is tremendous reason to be excited just by the sheer effort going in by many, and truly now dozens of pharmaceutical companies to try to develop therapies for patients with myeloproliferative neoplasms. And that is a dramatic departure of where we were historically. If I think back 20 years ago, when we were doing trials in myelofibrosis, no one was developing a drug for MPN patients. And the drugs that we used in trials, we were really trying to beg, borrow, or steal them from other diseases like myeloma or other things. Even drugs like hydroxyurea were approved for other things other than MPNs. So where we are now is tremendously different. As you think about trials, they really fall, the majority of the focus is in the area of the greatest unmet need, meaning the area where there really is no treatments that are effective. So the majority of trials are really in that group of patients with myelofibrosis who have already failed a JAK inhibitor. And I would say that there are multiple trials that are exciting that are looking at that group of people, and they fall in categories of alternative JAK inhibitors like momelotinib, which might help to improve anemia, Pocritinib, which might be used in people with really low platelet counts. There are drugs that might be added on to people having a suboptimal response with a JAK inhibitor, like Nevidiclax or CPI 0610, or being used as completely on their own after having failed a JAK inhibitor, like the LSD1 inhibitor from Imago that Kristen has helped to lead, that I'm involved with, or CPI 0610, or Nevidiclax, or Avid 200, or the Cartos MDN2 inhibitor. There's probably almost 20 different drugs in trials in that category. Next, there are trials ongoing that have started for newly diagnosed patients of adding a second drug in addition to a JAK inhibitor to see if they're more effective. So 0610 and Nevidiclax in that category. Can it be more effective? Should have mentioned in that prior bucket Imetelstat, another drug in that kind of post-Rux setting. So a lot going on in myelofibrosis, and although it's the smallest group of patients with MPNs, the focus is there because the need is the greatest. Now, it's still good news for everyone else, because things that are effective there will probably then end up evolving, depending upon their effectiveness and safety, to individuals with PV and ET. Now, in PV, there are some interesting things going on as well. There is, for lower risk patients, the question of using a hepcidin agonist like the protagonist drug, PTG-300, to see if you can make people phlebotomy independent in a way that's not iron deficient, but is perhaps a less intensive therapy than others. There, of course, are the pegylated interferon studies with Rho-pegylated interferon. There have been the MDM2 inhibitor studies as a second line. And then in ET, there are fewer studies, but still there are some important ones. There are ones both at my institution and others with the LSD1 inhibitor from Imago for people that have failed hydroxyurea. There's also a new phase 3 trial of Rho-pegylated interferon for people that have failed hydroxyurea. And that'll be an important option for folks as well. So a lot for folks to really be excited about the sheer volume and scale, but overall as a pattern, the drugs will probably first be tried in challenging situations with MF and then migrate to PV and ET over time.
Yes, go ahead, Dr. Jamieson.
Yeah, so I just wanted to follow up on those points. I think that we're in a really good position now because we're in a position to be able to combine therapies, whether it's pegylated interferon or Pegasus with a JAK2 inhibitor or a JAK2 inhibitor with a BET inhibitor. We have 2 FDA-approved JAK2 inhibitors to choose from, ruxolitinib or fedratinib, known as Jakafi or Inrebic, to be able to do these combination strategies. And I really think it comes down to the idea of really doing a sort of induction for people to get their disease into better control and then to be able to follow with a maintenance regimen. We've certainly done that with other diseases, and I think it looks like that's the way the MPN field is moving. I think imetelstat looks like a very interesting drug. This is a telomerase inhibitor. Telomerase is what puts caps on the ends of our chromosomes, and it looks like it might be too active in myelofibrosis. And the study so far looks like, in addition to looking like there is actually a response in some patients with myelofibrosis, it may actually prolong survival in some patients. So I think that's a very interesting drug and something that we may want to use for shorter periods because it can cause bone marrow suppression. But Dr. Mesa talked about the plateaus in this disease. It may be that we'll be able to extend that plateau and not have progression if we do intermittent dosing with some of these stronger agents that are called leukemia stem cells that have the capacity to clone themselves and go on to promote development of acute myeloid leukemia. The other stem cell active agents like hedgehog inhibitors, Glasdegib included, are now approved for AML when used in combination with low-dose Ara-C chemotherapy or with, 5-azacitidine or decitabine. So those are used in AML, but the question is, should we be using them earlier to get rid of these dormant leukemia stem cells that actually promote progression to acute leukemia? And I think that's where the field is also going. We'll be using some of the agents earlier in the course of disease now that we can monitor for progression so effectively with our molecular monitoring strategies, next generation sequencing, and new tools that will come to bear. So I think, we're going to have a completely different year next year. I think weirdly the challenges of COVID have increased scrutiny in terms of scientific scrutiny of data, which I always think is a good thing, and has increased the potential to do some of these studies. I anticipate we'll have more funding for science going forward, not just federally, but in the state of California, we have a proposition that funds stem cell research, and we expect that that will be approved. So there will be a lot more funding going into this kind of research because it really provides an essential insight into how cancer develops in the first place. I think it's a really important paradigm for predicting and preventing full-blown cancer development. So, I think we're in a very exciting field and a very important time in history where we can be optimistic about preventing progression. But we really need to understand the root cause of that and need to understand, do people make mutations repeatedly as opposed to making a mutation at one point in time and expanding that clone? And I think some people will make mutations repeatedly, so we need to be able to detect that and prevent it.
Kristen, do you have anything to add to this?
Yeah, I would echo everything that that the other panelists already said, but I think Yeah, as they both said, that this is such an exciting time in MPN drug development, and I don't think there's been a time like this in historical past in this disease. This is very exciting, and it's almost so exciting that it's hard to keep up with, even when this is your full-time job. So the way I think about a lot of these drugs that are being developed right now, this is an oversimplification, but in my head, I kind of put a lot of these newer agents into two different categories. One category of drugs or treatments that are targeting the malignant stem cell in these disorders, and then another category of drugs that are targeting the mechanisms of fibrosis, of actual scar tissue formation. And that is admittedly an oversimplification, because there's a lot of crosstalk between those two mechanisms within the bone marrow and within the body. So many of these drugs kind of target both of those, both the stem cell and the fibrogenesis, but that's the way I try to keep things a little bit straight in my mind. So as Dr. Mesa said, we have these JAK inhibitors that probably do a little bit of both. Some of the older JAK inhibitors, ruxolitinib and fedratinib, older or already approved JAK inhibitors, and then potentially some of the new ones, momelotinib or pacritinib. Some of the other agents like bomedemstat or IMG 7289, which is the trial that I'm leading, probably does a little bit of both, targeting both the stem cell and the fibrosis formation. The BET inhibitor probably does a little bit of both too. The Cartos drug, MDM2 inhibitor that Ruben also mentioned, probably targets mainly the malignant stem cell. So I think it really is going to be kind of a combination approach. And as Dr. Jamieson said also, it may be kind of an off and on combination approach as far as targeting the disease more aggressively early on in the disease course, and then employing more of a management or maintenance strategy long term. But I think these are all open questions, and it's so exciting that we actually have some effective, what look like effective treatments to play with and combine in different ways to hopefully get the best possible outcomes and improvements for people down the road.
Thank you very much. Okay, I'll have this question and start with Ruben or Dr. Mesa, because he has to leave, and that is, tell me your thoughts, or the patient would like to know, on stem cell transplants and when you might recommend that to a patient.
There probably is not a more complex decision than the issue regarding transplant for a patient with an MPN. And when we speak of transplant, we speak pretty much exclusively for those with myelofibrosis. That it overall is not a therapy we really consider in PV or ET because of the intensity of the therapy and the risk that comes with it. I like to say for folks, as it relates to myelofibrosis, likely the time to have a transplant is before you want one, meaning it can cure the disease, but it comes at a significant impact on your life for months to years, and comes with a risk of some potentially significant side effects, toxicities that can even end up being fatal. So making that decision is a complex one with you, your physician, and then frequently someone who is a stem cell transplanter. Which is kind of its own subspecialized expertise within hematology. At a high level, we think anyone that has, intermediate or high risk myelofibrosis, who is strong and healthy and young enough to go through that process well, potentially is a candidate. But when the timing of that occurs is quite complex, with variables being everything from your risk with your disease, your other health conditions, the who potentially would be the donor. Have you been on medical therapy like a JAK inhibitor, and has there been a response? So it's really quite complex. But I think it's an important discussion for myelofibrosis patients to have with their physicians, even if the outcome of that discussion is that it's not something we're going to pursue, or that we're not going to pursue now. it is an important discussion, and it is a complex one with about 10 to 20 variables, not the least of which is your own personal life philosophy. There are individuals that we have recommended transplant for that they, based on their own philosophy, prefer not to proceed with the transplant. And on the flip side, there are individuals that we offered as an option, but think that the odds are long for success. But these individuals philosophically are much more aggressive with their health care and have pursued transplant. There's not a wrong answer. So again, what I would encourage is it's a conversation. And if you don't feel that you're really finding individuals to really explain or engage in that conversation, then sometimes engaging others in that conversation is important. One cannot overemphasize what a complex decision this really is in myelofibrosis. And with that, I do have to leave this fireside chat, but I hope this has been helpful. Certainly, I think this is a wonderful idea, and I see hundreds of people on, and certainly look forward to participating in the future. And as always, there can be nothing better than having the opportunity to share the podium with Drs. Jamieson and Pettit, who are just extraordinary physician investigators.
Well, I can't thank you enough, my dear friend, and we really miss you. And so thank you so much for being here today. I know how busy you are. And peace be with you, brother.
Great, already. Everyone, take care. We'll see you again soon.
Nice to see you.
Bye-bye.
Thanks.
So Dr. Jamieson, would you like to speak to the issue of stem cell transplants and how you feel about those, and when you might suggest it to one of your patients?
Yeah, so I think, what's happening now in the field, as Dr. Pettit was alluding to, and Dr. Mesa stated so eloquently as well, is, we are able to assess risk a little bit more in terms of the likelihood of progression of myelofibrosis to AML based on mutation status. But it's still an issue because really you want to have your transplant before you have a litany of mutations and are transforming to acute myeloid leukemia. For most people with myelofibrosis, which is where we consider transplant, they're older and they have some higher risk features because of being older, high blood pressure, diabetes, just your weight. If you're overweight, that can be a negative prognostic factor. I think from, just what we're struck with or, having to deal with right now is that, it's only in Canada where they've done a randomized clinical trial to compare JAK2 inhibitors to bone marrow transplantation. And so before that study started, we didn't really have the data. It's being done in Toronto and across other healthcare sites in Canada to understand how much more bang for their buck will people get from targeted therapy with a JAK2 inhibitor, for example, as opposed to a bone marrow transplant. And it looks like initially the mortality with bone marrow transplantation is higher in the first 2 years, ranging from 10 to 40%, depending on the person and their other health-related issues. But then overall, longer term, they may survive longer. And that's a tough decision for people. I think when people have bone marrow transplantation, I don't call it a stem cell transplant because we're not actually selecting the stem cells, but hematopoietic cell transplantation, they're really sometimes trading one disease for another, and the other disease is graft versus host disease, where the other person's cells can basically target your skin, gut, and liver and cause inflammation in those tissues. So I think people have to be advised that even if they have what's called a reduced intensity conditioning transplant, their chances of having long-term remission are not as high as if they have a fully ablative allo. So in other words, their risk of mortality is lower with a reduced intensity conditioning transplant, but their chance of getting a complete remission are lower. And it comes at the risk also of having graft versus host disease, where they need a JAK2 inhibitor like ruxolitinib, or also known as Jakafi, to treat it. So I think people need to know there are risks and long-term side effects from transplantation. Some people are cured though with hematopoietic cell transplantation, and they're fine and they're off medications and they're really glad they had it. But they need to go in with their eyes open. I think that what we're starting to do in the field is look at, well, do we have to replace the entire immune system with somebody else's immune system? Or can we just replace part of the immune system? Can we consider natural killer cell strategies, NK cell therapy, to try and induce these longer term responses and reduce the requirement for these other medications, be they JAK2 inhibitors alone or in combination with other inhibitors, or interferon? So I think, you know, it's a hard question to answer without long-term data, but you know, fortunately, as we saw with the MPN Research Foundation meeting, it looks like the study is being done in Canada, and hopefully they'll have data that we'll be able to provide for patients, because evidence is better than speculation, and I think we'll be in a position to be able to say more about that in the next couple of years.
Okay, Kristen, I'm going to give you another question because we have 40 questions waiting and we need to start getting some of the, you know, I'm just going to, how about if I ping pong with the two of you? All right, so, Kristen, what treatments mask symptoms versus treating the underlying conditions? That's a great question.
That is a great question. I think that's tough with MPNs. I think for the most part, our goal is to make somebody feel better. So however we're making somebody feel better, making their quality of life better, making their symptoms better, I think that's a win. I don't generally worry about masking symptoms too much with MPNs. In general, for patients with MPNs, we're following the blood counts pretty closely, so I'm not usually worried that we're going to miss something like disease progression because we're treating symptoms. So it's not, masking symptoms isn't something I generally worry too much about. If somebody's feeling better, I take it as a win.
Okay, and Catriona, so this is going to be a different question for you, and that is, how long have patients been on Hydria without side effects? Is there a time when you might discontinue the drug?
Yeah, you know, I think overall we used to worry that it might suppress the bone marrow too much and ultimately lead to mutations, but now we can actually follow that with the next generation sequencing panels that most of us have at our disposal in academic medical centers. So I think it's more, how long do people derive benefit from hydroxyurea as opposed to the other newer therapies, JAK2 inhibitors, interferon, to reduce fibrosis and potentially reduce the JAK2 mutant allele burden or other mutations. And I think, you know, my answer to that is, let's make sure we're not missing progression to myelofibrosis. People can be well on hydroxyurea for decades. So if their disease doesn't progress, provided that they keep their hematocrit less than 45% or in a range that they're comfortable at below 45%, they seem to be fine. But I do think it behooves us to follow the patient's blood to make sure they're not acquiring additional mutations, and also to make sure that they're not progressing to myelofibrosis. So the answer is, I think it's a safe drug. I've had people on it for, you know, going on 2 decades. It seems to be okay. The question is it effective at reducing the signs, symptoms, and outcomes from myelofibrosis? And I think that's the key issue.
And I'll ask Kristen this question. Kristen, because you're doing some studies with MRIs and bone marrow, forgot the word. So how often does a person have to have a bone marrow biopsy? There's the word. And can that test be done through blood work instead of a biopsy?
Yeah, it really depends on the situation. So generally at the initial diagnosis, whether the concern is for ET, PV, or myelofibrosis, we generally do a bone marrow biopsy at the time of diagnosis to confirm exactly which MPN it is, and to make sure if it's ET or PV that's a suspicion, to make sure that there's no fibrosis, no scar tissue starting to form initially there. as well as to get the molecular studies, the gene mutation studies, and the chromosome studies that we need to help complete our prognostic tools, make our best possible crystal ball guess about how likely it is or not likely it is for the disease to progress down the road. So generally at least once a diagnosis. After that, it depends on the clinical situation. It depends on the disease. It depends on what's happening with the blood counts and what's happening with the person as a whole. For many people with ET and PV, they may never need another bone marrow biopsy down the road, or the triggers for bone marrow biopsy would be if the blood counts were changing, if they were starting to drop too low rather than being too high, they had been in the past. So we'd be looking for myelofibrosis progression, or if we were starting to see those blast cells, those cells that make us more concerned about an acute leukemia transformation. If we see those start to come up in the blood counts and the differential part of the CBC, then that would be another indication for a bone marrow biopsy. Or sometimes if people are feeling more miserable, even if the blood counts look stable, but the patient is telling us that something's wrong or something's changed, their symptoms have changed or their spleen size has changed, those sorts of things, those would also trigger another bone marrow biopsy. So even with patients with myelofibrosis at the outset, I don't routinely necessarily repeat bone marrow biopsies down the road unless I'm looking for a specific change, like a transformation to acute leukemia or like a progression of myelofibrosis. As part of a clinical trial, it's a little bit of a different story. Then we do biopsies at routine intervals to get that allele frequency in the bone marrow, see what improvements we're having for that, seeing if we're having any improvements in fibrosis, and following is more of a research question more than something that's necessarily going to change the patient's own management.
Okay. Thank you. That's interesting, very interesting, and that's a question that comes up often. I want to reiterate to those that are have been sending a lot of questions. We will gather these questions that do not get answered, and at our next conversations with specialists, we will ask those first. But in closing with our docs, I want to ask a couple more questions, and then we will give our industry partners an opportunity for a 3-minute update on their drugs. And these are kind of pre-ASH updates, so you will definitely be interested in staying for that. But in the last question to both of you is the same question I asked Dr. Mesa. And that is, you know, what do you see as the most promising situation in terms of treatment for your MPN patients and for the future? And Catriona, I know you talked about the work with NASA, which is brilliant. It's just so exciting and so wonderful. But anything else you would like to add to that?
I think that the capacity to reduce inflammation, reduce you know, bacterial infections and other things that drive these inflammatory mutators, APOBEC and ADAR. I know I keep going on about that, but I don't think that these mutations necessarily derive from radiation exposure in people. I think it can happen from inflammation driving these mutating enzymes. And, you know, that's something that has been found in a broad array of cancers. 40% of women with lobular breast cancer have activation of one type of APOBEC called APOBEC3B. 20 different cancers activate ADAR as they start to progress. So I think it's a 1-2 hit where APOBEC may be involved in initiating and propagating MPNs, and then they actually amplify that with ADAR, which is sort of like adding the liquid oxygen to the SpaceX Dragon when it's about to take off. Good news is I think we can reduce inflammation, whether it's with the JAK2 inhibitor or other mechanisms. I'm really excited about changing stem cell biology, and as Dr. Pettit mentioned, you know, there may be two things going on here where you have an inflammatory microenvironment that's promoting expansion of this pre-malignant stem cell. And you need to essentially target both. And I think that's really where the field is going, and we have a lot of opportunities to intervene earlier. So I think that if you look at why did we do so well with patients who have chronic myeloid leukemia, it's because we started treatment early. We didn't wait. There was no observation period. We said, you have the BCR-ABL mutation, you need to start treatment. And I think that's actually why people are alive and well 20 years after starting the single pill. I think it's a very effective one. I think Dr. Drucker did a lot for humanity together with Nick Lydon, but I honestly think we need to start earlier in the course of these diseases, and I think we will be able to make essential inroads with these newer medications combined with the JAK2 inhibitors, be it Inrebic or Jakafi combined with Nevidiclax, which is a BCL2, BCLX antagonist, Imetelstat, the telomerase inhibitor, the BET inhibitors. I think now we have such a plethora of options. It becomes that a challenge, but a good challenge to have. I think the good thing for patients is they have a lot of options now, and they need to be seen in an academic medical center because this is an important decision.
Thank you so much, and I agree with you wholeheartedly, of course, having been around for so long. Dr. Pettit, do you want to add anything to what Dr. Jamieson said?
Completely agree with all that. And I love what Dr. Mesa said earlier about that it's difficult to watch the sausage get made, so to speak. And I think that's very much the case in MPN research right now, that that things are moving. They don't always move as quickly as we want them to, but they're moving quickly. And I think we've certainly seen that with COVID in the popular press right now too. You can see how complicated medical research really is, with conflicting opinions and conflicting data over time. So I think exactly what Dr. Jamieson said, that initially with a lot of these drugs, they were started in the highest need populations, which are the patients with advanced myelofibrosis who have had disease progression through a JAK inhibitor and don't have any other necessarily standard great options. So that's kind of the situation where we had started with one single agent of a new treatment in those sorts of situations. And now we're fortunate enough to be seeing activity in those situations and moving those drugs up earlier and earlier in the course of people's diseases and combining them with other agents that have other targets. And I think that's really what's going to make the biggest difference in these diseases, is hitting them a bit harder and a bit smarter and a bit earlier.
Okay, so thank you both so very, very much. You are welcome to stay on as we look at 8 of the companies that have supported us that will be giving their updates. And again, to the guests that are on this webinar, we will combine your questions for our next event and then take new ones at that time. And that will be coming up in the next few weeks. So to Dr. Jamieson and Dr. Pettit, thank you so very, very much for your time. I know how busy everybody is, and for being a frontline person in the medical field. Our thoughts and prayers are with you always. And again, thank you so much for today.
Thank you, Anne, and to everybody who asked these incredible questions. We really appreciate it.
You ask great questions.
So thank you so much. I wish we could do this all day.
I know, we could, trust me, we definitely could. So we're doing as much as we can. We'll do as many as we can going forward, and I may call on you both again soon. So thank you so very much. And we are going to move on now and listen to our industry partners. They're just going to give a 3-minute brief update on what's happening kind of pre-ASH. And our first guest is from Insight, makers of Jakafi. And Kristen Griffiths is the Senior Manager for U.S. Public Affairs. Kristen, are you with us? There you are. Hello. Can't hear you.
Okay, how about now?
Perfect.
Great.
Perfect.
Great. So thank you so much for having me. I'm so excited to be here. I'm very pleased today to represent Insight. And I just want to thank Anne and the team at MPN Advocacy and Education International for giving me a few moments to speak about our company and its commitments to patients. So we are very thankful to you all, but also the American Society of Hematology for having ASH virtually this year. As Anne mentioned, we can talk a little bit about that. Of course, you know, we do have to hold some of the real meat and potatoes of what we'd like to talk about for ASH itself, but we're really proud at Insight that we will have a portfolio presented of more than 40 abstracts at ASH this year. The presentations, including an oral presentation of our phase 3 REACH3 study for ruxolitinib and in chronic graft versus host disease, or GVHD. So it really reflects the strength of our diverse oncology portfolio and our partnerships, and reinforce our commitment to finding solutions that serve patient lives, especially in cancer. So we're really excited about that, and more to come for ASH. So stay tuned for that. A couple other things I wanted to mention, and I guess I should just also take a step back and say that Insight Corporation as a whole is a Wilmington, Delaware-based biopharmaceutical company, and we're really committed to making a difference in patients' lives through our scientific discovery, really. And rigorous science is at the core of everything we do, from discovery and development of our novel medicines that help that meet serious medical needs in the oncology space, as well as other disease spaces. So I wanted to mention that we're committed to providing better outcomes to our patients through the medicines we develop, and also education that we develop to support the community, like the MPN community. One of the most important commitments to our MPN community is that we provide appropriate patients access to the medicines that we develop and produce. So for this reason, we have a program called Insight Cares to help assist appropriate patients and healthcare providers access our medicines and products. Insight Cares offers prescription insurance verification, prior authorization support, free drug and copay assistance for all those who qualify, and that's of course as terms and conditions as apply. We also refer to independent nonprofit organizations or foundations that may be able to provide financial assistance if it's needed, as well as ongoing education and support with a registered nurse. So patients who have any concerns about access should definitely contact Insight Cares for assistance. Also wanted to mention that we strive to enhance the support in the patient community to integrate the authentic patient voice throughout our initiatives. So partnerships like we have with Anne and her team have been really key to helping us understand the unmet patient and caregiver needs as well, including raising disease awareness and providing education information to the community. So for those of you who don't know, we do host a website called voicesofmpn.com where we can provide access to MPN information, patient stories, patients just like yourselves, access to information for the MPN community, events that we have, such as Facebook Live and patient meetings, podcasts, and also we have a symptom tracker there, which you should definitely check out. And then we created a program called MPN Heroes, and I'm very excited about MPN Heroes this year. This is a program that I'm taking over for Insight, and it's a wonderful program where we get to publicly recognize individuals who have excelled in caring for patients, or patients themselves, or people in the MPN community who have really advanced the science in MPNs to increase MPN awareness. In addition to that, so our actual MPN Heroes event is this Friday, December 4th. It's at 7 p.m. Eastern Time. What's wonderful about the event this year is it is virtual, and it used to be a closed event, but this time it's completely open to anybody to attend. So I would love to extend an invite to your viewing audience today. Please join us this Friday. Meet the 2020 MPN Heroes. We also have a wonderful keynote speaker, Devin Still. He is a professional athlete. He's a life coach, motivational speaker. He's also a childhood cancer advocate, and he will be our keynote this year. So I'm really excited to announce that, and I invite you all to attend. And I think Kathleen was gonna put the registration link in the comments or somewhere where people can access it. So if you would like to attend, you can click on that registration link, and it can you can join us on this Friday, December 4th, for that program. It's going to be great. I highly recommend it.
Thank you so much. And you know, we have to kind of move along, but Dr. Mesa received a Heroes Award. I did, and so did Dr. Jamieson. And so I have to tell you, it was a nice event. But thank you very much.
Yes, thank you.
And thanks for the support from Insight.
Yep.
And moving right along, our next industry partner, AbbVie, Brian Murray is with us. He is the Assistant Scientific Director. And Brian, please give us your update.
Thanks so much, Ann. Appreciate you and MPN Advocacy and Education International for allowing me to speak today. As Ann mentioned, I am an Assistant Scientific Director in U.S. Medical Affairs at AbbVie. For those who aren't familiar, AbbVie is a global pharmaceutical company and a leader in developing therapies for patients with hematological malignancies and other disease settings as well. And one of those disease settings includes myelofibrosis, and we are developing Nevidiclax for myelofibrosis, which Dr. Jamieson mentioned briefly towards the end of the conversation with the experts about 15 minutes ago. So Nevidiclax is an investigational agent. It's not currently approved by the FDA. It's a first-in-class oral small molecule. It binds to two proteins called BCL-XL and BCL2. BCL-XL is a known, plays an important role in myelofibrosis and has been shown to be overexpressed, particularly in patients who develop resistance to JAK2 inhibitors, such as ruxolitinib. So we think this therapy has a lot of promise in this space. It's currently being evaluated in 3 active and ongoing studies. The first study is a phase 2 study called REFINE. You might also hear it referred to as M16109. This evaluates the combination of Nevidiclax and ruxolitinib in patients with relapsed refractory myelofibrosis. We also have a cohort investigating Nevidiclax monotherapy in patients who have failed ruxolitinib and a cohort investigating patients who were previously untreated as well. And that study is actively enrolling. There's about 25 centers across the United States. We're looking for 130 patients total across all the cohorts. So there's still a lot of work to be done there. And the remaining 2 studies are both phase 3 studies, one in the first line setting called Transform 1 and one in the second line setting called Transform 2. Both studies are evaluating, again, the combination of Nevidiclax and ruxolitinib versus, in the case of Transform 1, ruxolitinib and placebo. In the case of Transform 2, which is, again, the relapsed study, best available therapy, and it's really the physician's choice between fedratinib, hydroxyurea, interferon, other therapies are allowed. The last thing I'll mention is that all 3, if you want further information on all 3 of these studies, there is a website that you can go to. It's called myelofibrosisresearch.com, and I'm fairly certain that this website was pushed out to the MPN Advocacy and Education International. They link to it. And so on this site, you can find more information about the studies. And there's a questionnaire on there as well that will allow you to determine if you're eligible for the study, which I think is really handy. And it's just a much more patient-friendly format than, say, clinicaltrials.gov, which can be very, which can be more challenging. So that ends my update. Again, thank you, Ann, so much, and others at the MPN Advocacy and Education International for allowing me to speak. Thank you.
Thank you so much, Brian, and thanks to AbbVie also. Thank you. And so our next partner is Imago, who has been with us for a long time. I know many of you know these folks. And Laura Eichhorn is the COO and CFO. And Laura, are you with us? There you are.
Give her 1 second.
I can see her. I can't hear her.
Are you able to hear me?
There you go.
Yeah.
Hi, Laura.
Okay, super. Hi, thank you so much, Ann. So in the interest of time, I'll give a quick update, but I just want to say I'm a bit of a Pollyanna at our company and within my family, and I'm always looking for the silver linings in any situation, specifically this pandemic. And I have to say this is indeed one of them. This forum And this event that Anne, Kathleen, and Ariel were able to put together on behalf of MPN Advocacy really is a testament to their dedication to the community. And I think it's a fantastic opportunity to have these fireside chats, the second chat with these physicians, two of which are involved in the Imago study. So we're really excited to be a part of this and to continue our support of the MPN Advocacy and Education International. So a little bit about our company. Imago Biosciences is a private company which was founded in 2012 and is based in South San Francisco, California. We're currently focused on the treatment of MPNs, and as you well know, these diseases pose a great challenge to both physicians, patients, and their families and caregivers. Our approach is a little bit different and unique to all the other drugs that are currently under investigation and available on the market. We approach our target genes our target is to approach the genes that regulate blood formation, specifically those regulated by epigenetic enzymes such as LSD1, an enzyme which regulates the maturation of blood cells in the bone marrow. Our drug, bomedemstat, or IMG 7289, was discovered by Imago in 2015, and it is an LSD1 inhibitor. This drug is an oral medication in a capsule taken once daily. We began our clinical research in the area of leukemia, and 1 year later, we transitioned to do research in myelofibrosis. The goal of the treatment of myelofibrosis is to improve symptoms and reduce spleen size, as well as reduce the number of malignant cells in the hope of changing the outcome for all patients. Bomedemstat is also being studied for the treatment of essential thrombocythemia with the goal of reducing the platelet count to normal. The FDA granted bomedemstat fast track, as well as for the treatment of both myelofibrosis and essential thrombocythemia, and more recently, bomedemstat was granted PRIME status in the EU, a status given to drugs that hold promise for new clinical benefit to patients. The myelofibrosis study is currently ongoing in the US and globally. The results have been presented at several hematologic meetings, and to date, there have been no safety signals. Most patients experienced improvement in their symptoms and shrinkage of their spleens. Most recently, bomedemstat is able to reduce the number of malignant cells, an exciting result we anticipate based on similar observation in the mouse studies. Dr. Kristin Pettit, who you all heard from today, from the University of Michigan and a clinical investigator on this study, will be presenting the most recent data at the upcoming American Society of Hematology meeting. Her session is on Saturday, December 5th at 7:30 a.m. Those results will be shared publicly. We can post data on our website once she has presented the presentation. Similar to our Insight colleagues, we don't want to spill the beans on this any too soon, but it's an exciting updated set of information. Imago is currently accepting patients into our study as well as ET and MF, and we would welcome any inquiries. For more information on our studies, you can visit one of three websites: our corporate website at www.imagobio.com. For our MF study, please visit www.myelofibrosisclinicalstudy.com. And finally, for our ET study, please visit www.etclinicalstudy.com. Thanks again, Anne, Kathleen, and Ariel, so much for including Imago.
Thank you so very much, Laura. We really appreciate it and appreciate the support that Imago gives us. Thank you very much. So moving along, Sierra is another organization that has been supporting us, thankfully, and Dr. Barb Glenecki is the Chief Development Officer, and she is with us to give us an update. Hi, I can't hear you. I can see you, but I cannot hear you. Can they hear her?
She's unmuted. You can't hear her. Might be the wrong microphone.
How about that?
There you go.
Okay.
Hi, Barb. How are you?
All right.
Thank you for joining us.
All right. Well, so thank you, Anne. And I know time is short, so maybe I'll just move very, very quickly. Sierra is a very small biotechnology company, and we're focused on momelotinib development and myelofibrosis. So this is our primary focus. Momelotinib is an oral bioavailable therapy, once daily therapy. It's investigational. It's undergoing clinical trial right now in a trial called the Momentum trial. Momentum is aiming to enroll about 180 patients to randomize 2/3 of those patients to momelotinib and 1/3 of patients to a control arm called danazol. But after 24 weeks, all patients are then allowed to continue on a long-term open label momelotinib once the endpoints at week 24 are captured. Momelotinib is unique. It's a JAK inhibitor, so it does inhibit JAK1 and JAK2, and by doing so should, in fact, control both splenomegaly and constitutional symptoms. But what makes it unique is that it is also a potent inhibitor of ACVR1. What this does is it really helps momelotinib have the potential to address anemia. So one of the major components of anemia, not only the fibrosis of marrow and other causes, but because myelofibrosis is such an inflammatory condition, many of the patients with myelofibrosis also develop an anemia of inflammation, where the iron is no longer available to the red blood cells. It gets sequestered. A patient can have iron overload, but that iron isn't available. So the aim of inhibiting ACVR1 is to allow the iron to become rapidly available. And what we have often seen is that anemia can be ameliorated, transfusion dependency can be reduced, or in some patients even eliminated. But maybe my most important point is what's coming at ASH. So ASH is coming up this week, and we have two important presentations, both of which are data sets from the previously conducted phase 3 trials, both Simplify-1 and Simplify-2. So on Saturday, Dr. Serge Verstovchek from MD Anderson Cancer Center, it has an oral presentation that provides the mature survival information, the mature survival analysis from both Simplify-1 and Simplify-2, first time ever presented. The other important presentation will be on Monday. It's a poster presentation by Dr. Jean-Jacques Kalajian from Paris. And again, looking at the Simplify data, which was a study of momelotinib against ruxolitinib, it will show the comparative activity across a spectrum of patients defined by baseline platelet count. So we look forward to seeing this data presented at ASH. And with that, let me turn it back to Ann.
Thank you so very much. This is so interesting, and thank you to Sierra. Our next partner is CTI Biopharma, and Dr. Sarah Buckley is the medical director, and she will be joining us. Is Dr. Buckley with? Oh, there you are. Hello. Hi, Sarah.
Hi, can you hear me?
Yes. Yes,
Wonderful.
I can.
Okay, hi there. Thank you very much. So my name is Sarah Buckley. I'm a medical director at CTI Biopharma. We're a small company in Seattle, and we're developing one drug, and that's Pocritinib, which is a novel JAK2 and IRAK1 inhibitor. And our main indication is for patients with myelofibrosis who have severe thrombocytopenia or platelet counts of less than 50,000. We consider this a very important indication because these patients often have more advanced disease than patients with higher platelet counts, and yet treatment options and often access to clinical trials may be limited by the low platelet count. So Pocritinib has already been studied in 2 phase 3 trials, both of which included patients with severe thrombocytopenia. And more recently, our PAC-203 second-line dose-finding study has just been published, and almost half of the patients on that study had severe thrombocytopenia. And that publication describes how we selected an optimum dose of Pocritinib that could lead to clinical benefit and be used safely in this patient population. So we now have a phase 3 trial called the Pacifica study. And Pacifica enrolls patients with myelofibrosis and platelet counts of less than 50,000. This study is open to patients who've either had no prior exposure to JAK inhibitors or who've had a limited prior exposure. So if you've had up to 6 months of prior exposure, you may be eligible. And the study randomizes patients 2-to-1 to pacritinib versus a physician's choice of therapy. The study is currently open in 64 sites, mostly in the US, but we have plans to expand, and we're currently working on opening up an additional roughly 80 or so sites in the US and around the world. I'd also like to take a moment to share an update about a pathway for accelerated approval for pacritinib. So our company met with the FDA a few months ago and agreed on data from our prior phase 2 and 3 studies that could support a new drug application or an NDA filing for pacritinib. And this would be for patients with myelofibrosis and severe thrombocytopenia. We've initiated this submission. We'll have more news in the new year, and we're excited and hopeful to be able to bring a new treatment option to this population. So in addition to this Pacifica study in myelofibrosis, I just wanted to note a couple other things. We're also conducting a randomized placebo-controlled phase 3 study of pacritinib in patients who are hospitalized with severe COVID-19. That's called the PREVENT study. And we're hopeful that pacritinib can offer benefit to patients during the pandemic. We'll have an interim analysis coming out in the new year on that. And then finally, ASH updates. We're excited that we've got a podium presentation at ASH that will describe results from a phase 1 study that's moving into phase 2 now, but the presentation will be on phase 1 data for pacritinib for graft versus host disease prevention after a stem cell transplant. So that's all I have. Thank you very much for taking the time to listen. If you have any questions about pacritinib or the Pacifica trial, please visit our website. That's ctibiopharma.com. There's also clinicaltrials.gov.
Thank you
Okay,
so very
thank you.
much. That was great, and thank you so very much. It's very interesting. We'll be watching very closely. So moving along to our next partner, Geron, and Lori Sherman is the Vice President and Project Coordinator in Clinical in Operations. Lori, are you with us?
Did we lose her?
Hi, can you see me? Can you hear me?
Yes, Lori, thank you so much.
Hi, Anne, good to see you. And hi, everyone. Thank you, Anne and Kathleen, for having me here today. And I know we're very short on time, and I think over pretty significantly now, so I'll try to be brief. So I work for Geron, and Geron is a very small biotech company. We are focused on one asset, imetelstat, which is a telomerase inhibitor. I believe you heard Dr. Jamieson and Dr. Mesa both refer to imetelstat. And we are developing imetelstat in hematologic myeloid malignancies, both myelofibrosis as well as myelodysplastic syndrome. And we did conduct a phase 2 study in refractory myelofibrosis, and there will be ASH data actually presented based on the data from that study, some updates from that study. And the results of that phase 2 study, which was called the EMBARK study, have led us to initiate a phase 3 study in refractory MF, and that trial is called the IMPACT MF study. It's currently in startup mode. We expect to have our first sites initiated and our first patients hopefully enrolled in first quarter of next year, so that's rapidly approaching. And we are conducting that trial in about 150 to 160 something sites, and it's a global trial. So if folks want any additional information around that study, you can certainly look on the Geron corporate website, or also reach out to Anne and Kathleen for my contact information. I'm happy to connect you with any further information around sites that may be close to you. That study is in refractory MF patients, so patients who have failed treatment with a JAK inhibitor, who are not expected to further have any response if treated with an additional JAK inhibitor. So imetelstat is kind of the next line of therapy there, and we are looking at survival in this patient population. I think you heard Dr. Jamieson mention that in our phase 2 study, we did see that there is indication of prolonged survival after treatment with imetelstat. And as I also mentioned, we are having several presentations at ASH. We have 3 poster presentations and, 3 oral presentations with updates from our Embark phase 2 MF data, as well as a trials in progress poster, where you can see more information about the Impact MF study that I just mentioned. So I hope I didn't talk too long, trying to wrap it up, because I think I'm out of time. So thank you again for having me today.
You did a beautiful job, and thank you. And again, we're watching you and all of these drugs. There's so much promise in the future. Very excited
Absolutely.
about that. Thank you so much, Lori.
Thank you.
So we'll move on to Constellation and Dr. Catriona Luptakova. If she is with us, if you'd like to give us a brief update. Hello, Catriona.
Hello, Anne, can you hear me?
Yes, you're there.
Thank you. Thank you. So hello, I'm Catriona Luptakova. I am the head of clinical development at Constellation Pharmaceuticals. And I would like to briefly introduce our small company. We are a biotech based at Cambridge, Massachusetts, with over 12 years of discovery and development history focused on epigenetics. Our lead compound is an investigational BET inhibitor, CPI-0610, that we are developing for treatment of myelofibrosis. As you know, myelofibrosis is characterized by several facets of the disease. On the clinical end, it's enlarged spleen and the symptoms. On the laboratory end, anemia and other cytopenias. And histologically, it is characterized by bone marrow fibrosis. And at Constellation, we are excited to explore ways that BET-governed regulatory pathway can deliver improvement across these disease facets, and are looking forward to presenting updated data from our phase 2 study called Manifest at the upcoming ASH meeting. We will have 4 clinical presentations I want to bring to your attention. On Saturday morning, Dr. John Mascarenhas will present data from Manifest Arm 3, which is the arm that's enrolling patients who are JAK inhibitor naive and receive treatment with ruxolitinib in combination with CPI-610. Dr. John Versosek will be presenting update from Manifest Arm 2, which is the arm that is enrolling patients who receive suboptimal response to ruxolitinib and receive an add-on of CPI-610. On Sunday, Dr. Moshe Talpaz will be presenting an update on activity of CPI-610 monotherapy in Arm 1 of Manifest, which is a study enrolling patients who are not candidates for JAK inhibitors, previously progressed or intolerant of JAK inhibitors. And last but not least, on Monday, Dr. John Mascarenhas will present our trial in progress, Manifest 2. So I will conclude by explaining what is Manifest 2. It is our global phase 3 study that is enrolling patients with myelofibrosis who have not been previously treated with JAK inhibitors, have DIPSS intermediate 1 or higher risk score, have an enlarged spleen and disease symptoms. And these patients will be randomized 1-to-1 to treatment with either ruxolitinib with placebo or ruxolitinib with our BET inhibitor CPI-610. Thank you very much, Anne, and a pleasure to be here.
I'm telling you, this is so fantastic. And our patients have not seen anything like this, as some of our physicians mentioned. I've been around since 2004 and there was nothing happening. I mean, it was just, this has been a slow crawl, and then suddenly everything is happening in this field, and we're so happy, very, very happy for our patients. Thank you so much, Anna. And we will close now, but as I said earlier to our guests, that we will, first of all, we'd like to thank our industry partners again. They have been fabulous to us. We could not do the work that we do here without their assistance. Secondly, we will be back. We will be hosting another program like this. We have collected the questions that you asked today that were not answered. Those will be answered immediately first when we do this again, which we hope will be in a few weeks. And lastly, please be safe. take care of yourselves and be optimistic, at least for the moment in the MPN field, because as you saw and heard, so much is happening and all good for you, for the patients and caregivers. So with that, have a wonderful day. Thank you for joining us, and we hope to see you soon.